Hi, everyone. My name is Josh Bilello. I'm a third year medical student at the University of Texas Medical Branch, currently the vice chair for the AMA MSS's Committee of Health Information Technology. Today, I have with me Professor Nicholas Terry. He's a professor and executive director for the Hall Center of Law and Health at Indiana University. Joining us, I have Cynthia Brown and Jason Marino from AMA Advocacy. Cynthia is with the Governmental Affairs for the AMA, and Jason is the Director of Congressional Affairs for the AMA. Today, Professor Terry will be talking a little bit about medical legislation that was adopted under COVID-19 and what this legislation might look like in a post-pandemic world. Then I'll ask some questions from our medical students section, and we will finish this session up with Cynthia and Jason, and they will talk a little bit about AMA's role in medical legislation. And so without further ado, Professor Terry, take it away.
Thank you, Josh, and I very much appreciate this invitation. So 2020 to 21 will be remembered not only for the syndemic in which the country simultaneously faced three overlapping public health emergencies: institutionalized racism, the continuing drug overdose crisis, plus COVID-19, but also be remembered for somewhat historical churn in our health law and policy. As you mentioned, Josh, you asked me to address what happens to temporary laws made during the COVID-19 surge when we begin transitioning to a post-pandemic world. I could waste your time debating the exact meaning of temporary, and you'd likely prefer a political scientist to explain just how and why temporary benefits and entitlements tend to get woven into our frameworks and become increasingly difficult not to renew once enacted. So rather, I'll address three categories of health laws or policies. First, temporary laws or changes to them that flowed from the federal COVID-19 emergency declaration. Second, reforms introduced by a series of stimulus packages, including the Families First Coronavirus Response Act, FFCRA, the Coronavirus Aid, Relief, and Economic Security Act, CARES. And third, I'll address the American Rescue Plan, or ARPA, and other actions of the Biden-Harris administration. First, therefore, the emergency measures. In January 2020, then Department of Health and Human Services, HHS, Secretary Azar declared a public health emergency for the US. Subsequent renewals created what is likely to end up being something like an 18-month natural experiment as we examine the costs and benefits of temporary changes in law and policy. Under this idea of the emergency powers, three sort of broad categories present: privacy and security, substance use mitigation, and telehealth. First, to privacy and security, 42 CFR Part 2, which is the confidentiality of alcohol and drug abuse patient records rule, also known as just Part 2, has always contained an exception to the consent provision that rule requires in the case of, quote, a bona fide medical emergency. And in March 2020, after the emergency declaration, SAMHSA, the administration in charge, part of HHS, issued guidance highlighting this exception and stating that information disclosed to the medical personnel treating such a medical emergency may be disclosed for treatment purposes. Also in March 2020, HHS issued a limited waiver of HIPAA sanctions and penalties applicable to hospitals that had instituted a disaster protocol. Essentially, sanctions and penalties will not apply to a hospital that fails to comply with the HIPAA privacy provisions with regard to a patient's agreement to speak with family members, requests to opt out of facility directories, distribution of notice of privacy practices, and a few other things. HHS, the Office for Civil Rights, which does HIPAA enforcement, issued a follow-up FAQ in March 2020 covering disclosures to first responders and public health authorities. These are all issues that crop up in daily practice outside of the national health emergencies. And so how these went through and what impact they had, I think, might well give rise to discussion going forward. On April 9th, 2020, HHS OCR issued an additional notification of enforcement discretion regarding the good faith participation of covered entities such as pharmacies in community-based testing sites. Next, telehealth. Expanded use of telehealth is viewed as a key healthcare strategy in the fight against COVID-19. On March 17, 2020, HHS OCR issued a notification of enforcement discretion applying to the use of some telehealth communications during the declared emergency that otherwise may not have been permitted under the HIPAA security rule. The notice expressly mentions non-public facing video chats, including Apple FaceTime, Facebook Messenger, Google Hangouts, and Skype as allowable under this waiver. It excluded public-facing applications, thank goodness, such as Facebook Live, Twitch, or, believe it or not, TikTok. Several states, including California, Indiana, Rhode Island, have expanded Medicaid reimbursement to most telehealth provided services during the pandemic, including mental health services, on the same terms as if they'd taken place in person. So, for example, New Jersey set up a dedicated telephone support line for those suffering from behavioral health issues during the pandemic. At the federal level, the Centers for Medicare and Medicaid Services, CMS, temporarily waived its antiquarian restrictions on Medicare reimbursement for telehealth, dramatically extending telehealth to patients outside of rural areas and allowing telehealth to be used by patients in their homes rather than just from other medical facilities. Telehealth will be one area to really watch post-pandemic. Health insurers and employers are likely to be in favor of further liberalization of telehealth rules and greater reimbursement, but large health systems that have built out bricks and mortar platforms may be more circumspect. Substance use mitigation. The slow increase in overdose deaths peaked at approximately 70,000 in winter 2017, then slowly declined with the year-over-year rate flattening to approximately 67,000. However, in spring 2019, a gradual increase became apparent with the year-over-year death rate returning to approximately 70,000 in winter 2019. Thereafter, there was first a steady but then far more dramatic increase to the most recent deaths that are close to 90,000 year-over-year. Although there are regional and state variations, these increases in the death toll have been caused by synthetic opioids, primarily fentanyl, and psychostimulants, primarily methamphetamine. Although there's been progress in increasing the number of treatment beds and the availability of naloxone, the overdose reversal drug, there are still massive gaps in community-based treatment for people who use drugs. The greatest barrier is what we call SUD exceptionalism, whereby more restrictive models apply to people who use drugs compared to others suffering from other chronic diseases. The most effective MOUD medications, methadone and buprenorphine, opioid agonist treatments, or OAT. They're also the most highly regulated. For example, a primary care physician can prescribe methadone for pain relief, but not for opioid use disorder. Tragically, opioid treatment for many requires traveling to inconvenient clinics and waiting in long lines because the DEA, Drug Enforcement Administration, requires that methadone must be dispensed by certified opioid treatment programs, or OTPs. During the public health emergency, DEA issued an exception so that methadone could be delivered by persons other than licensed physicians, clinicians, and through indirect means such as doorstep lock boxes. Additionally, SAMHSA is allowing states to request blanket exceptions for all stable patients in an opioid treatment program to receive 28 days of take-home doses of medication. Less stable patients may receive up to 14 days. Traditionally, buprenorphine prescribers have required a DEA waiver to prescribe the drug. As a result, only about 7% of clinicians are permitted to prescribe this incredibly important OAT drug, and dramatically smaller percentage, in fact, in rural areas. However, during the public health emergency, clinicians using telehealth even just telephone will no longer need to have an additional in-person meeting with the patient before prescribing the drug. This natural experiment looks like it has captured some imagination. Just recently, on April 28, 2021, HHS issued practice guidelines for the administration of buprenorphine for treating opioid use disorder that removes the waiver requirement, the waiver certification requirements for physicians and most other clinicians. On a related note, mental health services are still underfunded and far from reaching mandated legal parity. However, the Coronavirus Response and Relief Supplemental Appropriations Act, passed in December 2020, did include $4.25 billion in investment in mental health, a level of funding that I think needs to be sustained. So to my second topic, FFCCR, CARES, and then the ARPA changes. Let's start with an exception to the exceptions. Section 3221 of the CARES Act of 2020 dramatically reforms the Part 2 substance use privacy rule by essentially folding substance use patients into the HIPAA privacy rule. It also implements some robust and anti-discrimination rules for SUD patients. This I characterize as an exception to the exceptions because although contained in the CARES package of temporary changes, this is actually a permanent change, although its full implications won't be clear until we see new regulations. Earlier in March 2020, the FFCRA introduced a number of safety net changes such as paid leave and so on. It also provided states with a temporary increase in Medicaid funding. This was not as extensive as we had seen during prior public health emergencies. For example, during Katrina, the Bush administration essentially opened up Medicaid to all uninsured persons from the area. However, the FFCRA modification was conditional on what is called maintenance of effort, or MOE, meaning that states who took the money from the federal government couldn't use work requirements or any other way of reducing Medicaid eligibility or benefits during the public health emergency. The slightly later CARES Act contained substantial funding, including about $200 million to the FCC to improve broadband infrastructure. And this is part of a trend we're seeing of improving broadband and therefore making it more likely that we're going to see an expansion of telehealth and so on. And so to the Biden-Harris administration. Executive orders, EOs, the ARPA statute, and some of the administration's administrative powers. The ARPA changes, Josh, are more difficult to analyze under the temporary permanent binary you set up, because they're not only COVID-19 related in most cases, but they're also relatable to the inevitable law and policy churn that occur as administrations change over. By way of background, the Trump administration took the approach that the Affordable Care Act, the ACA, was a disaster and needed replacement. Now, no such replacement plan ever surfaced, and so arguably most of the administration's time was spent diluting the ACA by approving work requirements and other state Medicaid waivers designed to decrease eligibility, and also approving what we call junk health plans that would attract healthy persons away from individual marketplace plans, risk pools, and just otherwise looking to deprecate the subsidized individual market, which is sometimes called the Obamacare. So let's start with the Biden executive orders. Clearly, you can also see in his earliest EOs some longer term agendas that are being set out, such as vastly improved public health data management, which was one of the major flaws we saw during COVID, changes to health equity, and obvious plans to combat discrimination on the basis of gender identity or sexual orientation. Other EOs have had more immediate effects. So, for example, one of President Biden's first EOs in January reopened enrollment to the health insurance marketplace, the federal marketplace, for 3 months. And in March, this was extended still further, so it remains open until August, allowing people to sign up, primarily persons who previously couldn't afford individual marketplace plans or had lost their health insurance when they lost their job during the decline in employment during the pandemic. Turning now to the statute, ARPA, this March 2021 legislation exemplified the new administration's ambition to rebuild the safety net and strengthen the ACA. However, and crucially, the ARPA funding will sunset, suggesting that there's going to be a later legislative fight to make the changes wrought by ARPA permanent. And that's going to be very difficult to do without a filibuster-proof majority in the Senate. So these are literally temporary changes unless the politics change and they get made permanent during the Biden administration. First, employees who lose jobs or benefits during the pandemic qualify for 100% COBRA health insurance subsidies. Next, ARPA introduced major changes to the eligibility for and the amount of subsidies through tax credits available to purchasers of individual health insurance through the ACA marketplace. These changes included eliminating the annual income cap and limiting the amount households pay to 8.5% of annual income. Interestingly, some parts of those subsidy changes would become permanent under the Biden-Harris proposed American Families Plan, but see above whether that is a likely candidate for congressional approval. Next, COVID-19 vaccines and treatments, as you know, are covered without cost sharing or any charges by Medicaid and CHIP at 100% of the Federal Medical Assistance Percentage, or FMAP, which is the Medicaid formula. States have the option of extending that to uninsured persons. This provision, which governing vaccines and treatment, which joins free COVID testing that we've had since back in March of 2020, may not seem particularly earth-shattering, or at least for those of us with employer-provided healthcare. But for almost 30 million uninsured persons, including undocumented persons, one could argue this has been a unique taste of free universal coverage. And for tens of millions of underinsured persons, this was a taste of healthcare without expensive cost sharing. Now, the bad news is, while these statutory requirements will continue during the emergency, already we're seeing voluntary waivers of cost sharing by some health insurers being withdrawn. Next, there was a temporary increase put into the state-based FMAP, again, the Medicaid formula, to encourage non-expansion states, particularly the high population states such as Georgia, Florida, and Texas, to expand Medicaid. $64,000 question: will a large influx of federal monies overcome political opposition in those states? It hasn't yet. Is this going to be another bite at the cherry? Finally, I'll turn to the policymaking and administrative powers of the new administration. It would be fair comment, Josh, that these are not the sort of temporary changes that you asked me to comment on. However, if we continue without congressional majorities that can enable legislation, so also we will continue this rather soulless sight of administrations not doing a lot more than reversing the actions of the prior administration through regulation or changes in policy. Now, for extra credit, I would suggest you read the Patient Protection and Affordable Care Enhancement Act of 2020, HR 1425, which was passed by the House of Representatives last year. And that sort of provides a roadmap for reversing the last administration's attack on the ACA. The most obvious examples of administrative policy making that are already in play have been the new administration's withdrawal of Medicaid work requirement waivers. They also canceled Texas's Medicaid funding waiver. And with regard to what is called notice and comment rulemaking, they've reversed the Trump administration's Title 10 family planning regulations, and those regulations that allowed for non-ACA compliant health plans. I'm sure I'm already way over time, so 2 quick points to finish with. Although the Affordable Care Act is historically popular, at least as of the date of this recording, the Supreme Court has not yet decided Texas versus the US, a broad challenge to the constitutionality of the ACA. Now, by letter, the Biden Department of Justice has notified the Supreme Court that the new administration disagreed with the arguments previously made by the prior administration that the ACA was unconstitutional. Now, it is still possible, if unlikely, that the court could side with the plaintiffs and kill the ACA with the likely devolution into healthcare chaos that would then follow. And then my final point is that if COVID-19 and the reaction to public health mitigation efforts left us with one tragic conclusion, it was that our social contract is currently in variance with concepts such as solidarity or related models of health interdependence. I guess the question for both public health and clinical care is, where do we go next? Thank you.
Thank you so much, Professor Terry. Such an informational piece, and I'm sure our medical student section will learn a lot about what you talked about today and hopefully get fired up about health policy writing and getting involved. So I just want to take some time to just ask some questions from our medical student section. So first, how can medical students and also other healthcare providers learn more about the topics discussed here today, and what resources are out there and available to them?
So I don't know whether you heard of it. There's this new thing called the Google. And apparently you can make searches, but if you don't go that route, there are some truly wonderful sources of information. I would point to particularly the Commonwealth Fund and also KFS, which is funded by Kaiser. And these are incredible resources that combine sort of data, chunking, political science, some law, some policy, and they're great places to really educate yourself on them. They also tend to be very good if you're a visual learner at doing diagrams and graphs and things like that, rather than horrible chunks of text like I just put you all through. So I'd warmly recommend those kinds of resources.
Awesome. All right, next question. So what all goes into like making these laws, during an emergency such as COVID-19, and how can medical students and other healthcare providers get involved in the lawmaking process?
Well, generally speaking, these things are sort of preordained. I mean, there is a national health emergency playbook, right? That was used during Katrina, that was used during COVID-19, and certain things just sort of happen automatically, like the HIPAA waivers and so on. Other things tend to filter in through think tanks or interest groups, and I'm sure AMA leadership, particularly congressional agency folks who work on these things, have their own lists of things that they would like to see incorporated either temporarily or permanently. And that's typically the best way that you can you can influence these kinds of things. The trick is you need to have these listed out and presented to the right government departments before the emergency. It's unlikely that when there is an emergency, they're going to stop everything and write to medical students or even my law students and say, what should we do next?
Great. Again, thank you so much, Professor Terry, for all your insight. Now I'll kind of turn it over to Jason and Cynthia from AMA Advocacy to kind of discuss how AMA plays a part in all this legislation. Jason, Cynthia?
Why don't I start and then turn it over to Jason? He's our Hill expert, but I can tell you a little bit about what we were doing during the pandemic in terms of trying to seek some of those temporary changes in terms of expanding access to telemedicine, allowing for phone-only conversations, particularly when you consider Medicare, the elderly, a lot of rural people who don't have broadband access. That was the only way they were going to get care and continue with continuity of care. Also some of the expansions of Medicaid and so forth were things that we supported. I think as we go forward, you know, it is going to be a challenge. Which things are going to be permanent versus which things are temporary in nature. For instance, we were looking at payment issues with Medicare. There was a sequestering effect that we got rolled back. That's going to come back. I don't know if there's much we can do about that. But other things like the telemedicine expansion, we're certainly going to try and keep most of those permanent. There are some scope of practice issues too that make physicians uncomfortable, but it was a public health emergency, so we had to engage the whole healthcare system in getting people tested, vaccinated, and so forth. Those things are being taken advantage of now, and we're going to be living with them in the future. And the other point I think I would make before turning it to Jason is that a lot of these changes that we're seeing now are being done with reconciliation as a vehicle on Capitol Hill. That's how they get by with the 50 votes and not having to have a filibuster-proof majority. A lot of policy changes that people want to see can't be done that way. And so they really have to be in a bipartisan package, and that's going to limit some of the things we can do in the future or affect the shape of what we try and do in the future. Jason?
Sure. I'll just build on that. I'll say last year, there were 5 COVID relief packages. They were all bipartisan. I think they added up to $3 trillion. And as the lobbying team of the AMA, you know, we're very much working with all of the committee staff and the leadership staff on both sides of the aisle, both the House and the Senate, seeing early drafts, getting some things inserted to benefit physicians and patients, and when things went a little too far, checking those. So there's a lot of back and forth all last year. And I'll say going forward, I'll just take one example of a tangible example on telehealth, just build that out. In that before the pandemic, there was less than 1% of Medicare beneficiaries that actually used telehealth. And Professor Terry talked about antiquated Medicare rules. Well, they were written in the 80s when no one had iPhones, and you had to drive to a facility to do the telehealth visit, and you had to be in a rural area or it wasn't even covered. And then the laws never changed. And every time you try and change it, and then in recent times, it triggers what's called a CBO score. Congressional Budget Office does a 10-year score. And if it's super high, usually things get paralyzed. And we had been working on a bill called the Connect for Care Act, was a bipartisan bill in the House and Senate to kind of lay the foundation. And we had some waiver provisions if there was an emergency. And so when this COVID happened, we were able to trigger that provision in one of the early COVID bills last year to get it going. And now that we've had a year in, when you talk to senators and House members, they always tell you the one silver lining of this whole COVID pandemic has been telehealth and how it's worked. And there's been more innovation in the last year than the last 10 years. And it happened quickly, and patients are getting used to it. Once you do it once, then you kind of understand it better. It's not for everyone, not for all circumstances, but we don't want to go back. And so we've worked on a bill in the House and Senate that would permanently lift the geographic restrictions and the originating site restrictions, meaning that you can do telehealth from your home, from your car, people are driving to commuter parking lots where there's Wi-Fi because they don't have it in their home, and they're doing telehealth there, public libraries, and opening it up. And and we're building the case. What we're hearing back, there's concern about, is it going to lead to increased utilization? Are people going to do a visit in person and then the telehealth? Or is it going to lead to a lot of fraud and abuse? Is the quality going to be the same? What's it going to cost? Things like that. And we're arguing that we haven't seen a spike yet in utilization, but in some cases, for some underserved communities, some minoritized communities, it's been an increased utilization, but that's a good thing because you're actually treating things, chronic diseases, preventing hospitalizations, you're saving money downstream. So some increased utilization is a good thing. And then there's a lot of confusion on telefraud, which has been going on for years, and it's different than telehealth. And so we're doing the classic, make friends on both sides of the aisle, bipartisan all the way. And that's, and history shows that when a big bill that has significant change is bipartisan, there's buy-in, it tends to be more enduring and less subject to, attacks when there's change in power. And the margins in the House are 5 votes, Senate 50-50, the House could very well flip. And so you have to always be ready to work with everyone and come to the table. And we play a good role at the AMA, bringing people together, and we can be a good convener and a good validator on both sides. And a lot of people trust physicians and what we have to say. So we are very judicious and engaged on that. And I have a lot of hope going forward that, you hear a lot in the news about the battles, but behind the scenes, there are some things that are constructively going on. It just takes some time. I'll leave it at that.
Awesome. Thank you both so much. I think that's a great way to end today's session. Professor Terry, thank you so much for being here and giving us and the medical student section a wonderful lecture on health legislation and COVID. I know I learned a lot from listening to you, and I know so many other medical students will as well. Also, thank you, Cynthia and Jason from AMA Advocacy, for being here and showing us a little bit about what the AMA is doing and their current role in health legislation. Thank you all so much again, and thank you to our listeners. I think that's a wrap.